Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 449 of our pharmacotherapy series, which majors in colorectal cancer. This video focuses on patient KTM from part 448 of this pharmacotherapy series. KTM was discharged from the hospital after 4 days without identification of any infection. KTM presents to clinic to receive a second cycle of FOLFIRI plus bevacizumab. He is now more cognizant of chemotherapy's adverse effects. He states that after his first cycle of chemotherapy, he also experienced abdominal cramping followed by profuse watery bowel movements for 3 days. He reported periods of nosebleeds lasting up to 2 weeks as well, which he never had in the past. The following laboratory values were also noted. A WBC count of 4.5 times 10 power 3 cells per microliter. Hemoglobin of 12.5 grams per deciliter. A platelet count of 210,000 cells per microliter. A serum creatinine of 1.3 mg per deciliter. What can be done to alleviate or avoid these symptoms? KTM would like to know more information about the side effects of chemotherapy agents he is receiving. Kindly suggest a response to this concern. The incidence of irinotecan-induced diarrhea varies depending on the dosing schedule used and its combination with other chemotherapeutic agents. Trials in metastatic colorectal cancer have reported rates of grade 3 or 4 diarrhea of 20% to 30% depending on which irinotecan-based regimen is used. The active metabolite of irinotecan, SN38, is capable of producing acute abdominal cramping and diarrhea, which is a cholinergic-mediated process. Administration of subcutaneous or IV atropine at doses typically lower than those used in the cardiac setting is recommended for the treatment of acute diarrhea caused by irinotecan. The occurrence of diarrhea can also be delayed. Thus, the use of an oral antidiarrheal is recommended if this occurs. A regimen of oral loperamide 4 mg with the first loose bowel movement, followed by 2 mg every 2 hours during the day or 4 mg every 4 hours in the evening, is recommended until the patient is diarrhea-free for a period of 12 hours. If severe diarrhea symptoms persist for more than 48 hours in spite of these measures, patients should be instructed to seek emergency medical attention. Insufficient hydration resulting from diarrhea may lead to electrolyte losses and life-threatening consequences. Although the vascular endothelial growth factor inhibitors, such as bevacizumab, ziv-af-liber-cept, and ramucirumab, may share some overlapping toxicities with traditional chemotherapy, the majority of their effects are unique. Although cytotoxic agents are associated with myelosuppression, anti-angiogenesis agents, i.e., vascular endothelial growth factor inhibitors, do not target proliferating cells. Hence, they do not cause this type of toxicity. All vascular endothelial growth factor inhibitors carry the risk of grade 3 or 4 bleeding events and gastrointestinal perforation which, while severe and require immediate medical attention, are also relatively rare, that is less than 3% and less than 2% with bevacizumab, respectively. Other adverse events deemed as vascular endothelial growth factor inhibitor related are arterial thrombosis, hypertension, proteinuria, and wound healing complications. Monitoring of blood pressure and the pharmacologic management of diagnosed hypertension while on vascular endothelial growth factor inhibitor therapy is essential. In addition, because of the wound healing complications, the use of vascular endothelial growth factor inhibitors should be stopped at least 6 to 8 weeks prior to planned surgery and should not be resumed until the patient has fully healed, at least 4 to 6 weeks. Finally, a rare but serious side effect of posterior reversible encephalopathy syndrome, abbreviated as PRE, has been reported with agents that target vascular endothelial growth factor including bevacizumab, requiring immediate medical attention and discontinuation of therapy. The epistaxis KTM is experiencing with this cycle of chemotherapy may be attributed directly or indirectly to his current regimen. Although fluorouracil and irinotecan may also cause bleeding, this is usually related to their myelosuppressive effects on platelet progenitors. Because KTM has a platelet count of 210,000 cells per microliter on his recent laboratory work, this bleeding is more likely associated with bevacizumab use. About 10 months into his treatment, KTM had a CT scan that suggested progression of the liver and lung masses. Cytogenetic analysis of tissue from his old tumor biopsy was requested. The cytogenetic results suggested wild-type RAS and no mutation of BRAF. What should be the best second-line treatment option for KTM's metastatic disease? KTM has not received anti-epidermal growth factor receptor monoclonal antibody-based chemotherapy. A tumor tissue analysis now reveals that it contains wild-type RAS and negative BRAF cytogenetics. Therefore, KTM may receive benefit from anti-epidermal growth factor receptor monoclonal antibodies. In addition, irinotecan in combination with epidermal growth factor receptor antibodies have synergistic activity. Therefore, a regimen of irinotecan and anti-epidermal growth factor receptor, such as cetuximab or panitumumab, combination would be a good choice. In many cases, the fluoropyrimidine is continued as well. KTM will receive the following combination chemotherapy regimen. FOLFIRI, dosed as before with the dose reductions for irinotecan as previously noted because of his episode of febrile neutropenia, and cetuximab at 500 mg per meter squared. Each cycle is to be repeated every 2 weeks. So my questions to you read. What is the most common adverse effect KTM is likely to experience with his new anti-epidermal growth factor receptor therapy? How can this toxicity be minimized? In addition to diarrhea, dermatologic toxicity related to epidermal growth factor receptor therapy occurs in more than 90% of metastatic colorectal cancer patients treated with these agents. Epidermal growth factor receptor skin reactions typically occur within 7 to 10 days of therapy, and most often present as a maculopapular rash on the face or upper torso of patients. The rash may cause discomfort and reduce quality of life. Both cetuximab and panitumumab have recommendations for dose reductions or the withholding of therapy based on rash severity. Collaborative efforts have been made across clinical disciplines to develop treatment strategies for epidermal growth factor receptor-induced dermatologic toxicities based on their severity. Strategies for preventing or limiting the severity of epidermal growth factor receptor dermatologic toxicities have also been explored, including the use of a daily regimen of skin moisturizer, sunscreen, topical 1% hydrocortisone cream, and doxycycline. In addition to their antimicrobial properties, the tetracycline class of antibiotics possesses anti-inflammatory properties and anti-proliferative effects on lymphocytes, which makes it a reasonable class of agents to consider given the proposed mechanisms involved in epidermal growth factor receptor rash development. 2 studies have revealed that the use of either minocycline or doxycycline as preemptive treatment, i.e., given prior to the first dose of either cetuximab or panitumumab and continued throughout therapy, can significantly reduce the severity of the rash, but not the overall incidence of occurrence. KTM would most likely develop an epidermal growth factor receptor inhibitor rash. A strategy focused on skin moisturization and protection combined with a daily application of hydrocortisone cream and the administration of doxycycline 100 mg twice daily or another tetracycline derivative could also be considered. KTM comes in for his first dose of cetuximab with fall fury. Within minutes of receiving the initial cetuximab infusion, KTM becomes hypotensive and begins having difficulty breathing. My question to you reads: what measures should be taken as quickly as possible? The incidence of grade 3 or 4 infusion-related reactions reported in clinical trials is less than 3.5% with cetuximab and even less for panitumumab. Because cetuximab is a chimeric monoclonal antibody, the higher incidence of reactions is not surprising. Therefore, cetuximab administration requires premedication with diphenhydramine, whereas panitumumab does not. Although the incidence estimate for hypersensitivity is less than 5%, these reactions may be underestimated, especially in the middle southern region of the United States, where a higher incidence has been observed. It is not currently known why there is a greater propensity for severe hypersensitivity reactions in patients in this region of the country. Because of the severe nature of the reaction experienced by KTM, re-challenging with cetuximab at this point would be contraindicated. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 450.